Hey guys, welcome back. So this is a lecture on chapter 32, lower respiratory medications. So let me share my screen and let's get started. We're going to make this straightforward as we possibly can for all of you. So here we go, lower respiratory meds. So the first couple pages, as I typically do, I'm telling you what meds you need to know. So first one is montelukast. It's also known as Singulair. That's the trade name. It's a leukotriene inhibitor. It's used in prevention and treatment of chronic asthma for adults and kids older than 12. Remember with this one, you give it at bedtime. It's always given at bedtime, okay? Adverse reactions like GI reactions like an upset stomach, which is dyspepsia, possibly abdominal pain, and respiratory reactions sometimes include flu-like symptoms and a chronic cough. So, you want to warn the patient about that. Do not use this if the patient has bronchospasms with asthma attacks. A bronchospasm is when all the bronchioles, the main one, that your airways just go, and that can actually be dangerous. So if that is happening, you don't want to use montelukast. There are different drugs like albuterol, which we're going to talk about in a minute, that work better for that. The other one you need to know is theophylline. We call it theo. It's actually a derivative of another medication called aminophylline. There's xanthine derivatives, not that that matters, but you may not find theophylline in the F.A. Davis drug book, but you would find aminophylline. Either way, they basically act the same. They're given usually IV, and they're used to manage, long-term management of chronic asthma, COPD. Same thing as far as adverse effects or nervousness, anxiety, tachycardia, and those types of things. Okay, so we're back. Let me get back to this. Sorry for that little interruption. So we were talking about theophylline. You do need to know that theophylline is one of those drugs that we have to monitor the amount of drug in the patient's blood, which that's a serum drug level, okay? Because the patient can become toxic. So you need to know that theophylline, 10 to 20. And like I was saying, adverse effects are kind of, the same thing, nervousness, anxiety, tachycardia. This is not the drug of choice if somebody's got hypertension or already has cardiac issues like arrhythmias, a rhythm that's kind of crazy with their heart. And that's it for theo. Next is albuterol. And albuterol is kind of the queen mother, if you will, of the MDIs, metered dose inhalers, or some people call them puffers. It's a short-acting bronchodilator. They call it a rescue inhaler. In other words, if a patient is having an acute asthma attack, wheezing, having a hard time breathing, albuterol is the drug that you use, right? So it's a sympathomimetic. Immediately, as soon as they take a puff, it dilates their airways and it reduces the wheezing and increases the exchange of air, so it relieves their symptoms. But they should know that adverse effects are tachycardia, palpitations, cardiac arrhythmias, nervousness, anxiety, jitteriness, hypertension, insomnia, those kinds of things. Most of these respiratory meds have those adverse effects potentially, right? But do you want to be able to breathe and be a little jittery? Or do you want to not be able to breathe, right? So again, everything is risk versus benefit. And when we look at these meds, if they have a little bit of nervousness or anxiety for a few moments after use, but the drug relieved the asthma attack, then that is a win, right? You do want to be careful in patients that have cardiac arrhythmias or hypertension, or even glaucoma. Glaucoma is a condition in the eyes where there's a buildup of intraocular pressure. So there's pressure behind the eyes. And so the adverse effects of the hypertension and all those things can make the glaucoma even worse. There's one key thing to remember with albuterol. If the patient is ordered a short-acting and a long-acting bronchodilator, and oftentimes they are, you should always instruct them to use the short-acting one first. Because what will happen is they'll take the albuterol, and that will open up their airways, which will allow them to better absorb the next drug, which is the long-acting bronchodilator. That makes sense, doesn't it? Okay. The other ones you need to know, tiotropium, also known as Spiriva. This is a fun drug. It's a long-acting anticholinergic drug, and it's used once daily. It's a bronchodilator. So where albuterol is a short-acting bronchodilator, tiotropium is a long-acting bronchodilator. It's not a rescue inhaler. It's used usually once a day. Treats COPD. It comes in a capsule, and the capsule gets inserted into this little gadget that's like a meter dose inhaler, sort of, but it flips open, the capsule goes inside, and then they close it. When they push on it to inhale, there are two pins that pierce the capsule, and the powder inside the capsule is released, and that is what they are inhaling, right? Make sure that they know to not swallow the capsule. Now, you may think it's common sense, but when this drug first came out, believe it or not, patients would, go pick it up at the pharmacy, not really read the instructions, and the first thing they would see are the capsules. And it would say, use once daily, and they would swallow the capsule. So that is a no-no. The capsule goes into the inhaler. Adverse effects, it can cause dry mouth. Anticholinergics can cause significant dry mouth, which is called xerostomia. So make sure you know that. Okay. And then last but not least, we use corticosteroids that are inhaled. And the one that we'll talk about is fluticasone. So it's an inhaled corticosteroid. Corticosteroids decrease inflammation. So the ones for bronchial inflammation, fluticasone is one of them, decreases the inflammation in the bronchial airways and allows the patient to breathe easier. One of the big things with corticosteroids that are inhaled is the risk of candidiasis, or fungal infection in the mouth and throat. So you make sure you educate the patient. Always rinse their mouth immediately after use, because they can develop candidiasis and it is definitely painful. And then they'd have to use nystatin, swish and swallow. So make sure you remember that. You don't want to use corticosteroids in patients that have seizures or acute bronchospasms. So back to that, a corticosteroid can actually make those things worse. It can bring on a seizure, right? So there you go. Before you give any respiratory drugs, that just makes sense, pre-administration, take their vital signs, blood pressure, pulse, respiratory rate, and make sure you're auscultating the lungs, all fields, anteriorly and posteriorly, and you're documenting any dyspnea, shortness of breath, any cough. Is it productive? In other words, or non-productive. If it's productive, better tell me what it looks like, what they're coughing up. What does the sputum look like? Is it purulent, thick? Does it have color to it? Is it yellow? Is it green? Is it clear? Right? Document all that. Are they wheezing? With asthma, you will hear typically expiratory wheezes, because with all of the obstructive pulmonary diseases, including asthma, emphysema, they can get air in, but it's difficult to get it back out. So you'll hear, that's a wheeze. Okay, it's musical, right? Any other adventitious breath sounds that you can hear? The word adventitious means they're not supposed to be there, right? So a breath sound that you should not be hearing, like a wheeze, is adventitious, right? If you're hearing normal breath sounds, that's vesicular or bronchovesicular. They're normal, like when you listen, you hear, the air moving in and out, the normal breath sounds. Also document if you see them using accessory muscles when they're breathing, where they're lifting their shoulders to take a breath, right? If the patient has chronic asthma, you always want to make sure that you're documenting any allergies, because allergies can trigger an asthma attack. They should be keeping a journal about how often they're having asthma attacks and when they're using that rescue inhaler, how frequently, right? And what's the severity of the attack, right? Any factors that can cause or relieve the attacks, and then any other medications that they're either taking now or that they used to take, because that's important to know, okay? Nursing diagnoses, when you're talking about lower respiratory, here are 4 of the big ones. Anxiety related to feelings of breathlessness. You get nervous when you can't breathe. Ineffective airway clearance related to bronchospasm. Impaired oral mucous membranes related to dryness of the mouth or irritation, so xerostomia or candidiasis. And then imbalanced nutrition, less than body requirements. This can be related to decreased appetite caused by dyspnea. Again, if you can't breathe, you don't want to eat, right? or it can be caused by nausea or heartburn or a funny taste in the mouth from some of these drugs, right? So there are the nursing diagnoses. Here are the actual implementation or interventions for each of those four. So make sure you read through, like this is the one for anxiety, you know, here for altered nutrition, you know, people should be getting small frequent meals, not 3 big meals a day. They shouldn't be drinking while they're eating. They should drink after they're eating. Think high protein, high calorie, big bang for the buck, right? Keep them in an upright position after eating, etc. And then impaired oral mucous membranes. Everybody should always be brushing their teeth. So if you ever, you know, see a question and one of the answers is, you know, temporarily don't brush your teeth, you would never not brush your teeth, right? They should be using very good oral hygiene, brushing their teeth, cleaning the inhalers, right? And rinsing their mouth to decrease the incidence of candidiasis. And then if they're having a bronchospasm, hopefully you're giving them some medication like a corticosteroid to make that stop, or I'm sorry, a bronchodilator to make it stop. But you want to make sure you're checking their vital signs. Usually it's every 5 to 15 minutes. They could possibly have oxygen on, right? And they more than likely would have a pulse ox on, you know, just to see how their oxygen levels are. And we may even order ABGs on that patient if they were in the hospital. All things to think about. So those are your interventions, you know, and you always make sure that you educate the patient and the family specifically about the med. So if they're using albuterol, then you specifically educate them about the things that I already spoke about with albuterol. What are the potential adverse effects of it? Same thing with montelukast. What are the adverse effects? When should they take it? Et cetera, right? So your client education needs to be specific to that medication, okay? It can't just be take as directed, finish all your meds. That's understood, okay? So I'm starting to say this now so that people understand that you want to be specific, because you won't get a question on the boards where the answer is take all your medication as directed. It's going to be a specific question, so you need to be able to answer it, okay? So make sure you remember that. And then how do you evaluate the effectiveness? Well, are the symptoms gone? Do they feel better? Can they breathe? Is their nutrition good? Do they not have candidiasis? Is their airway maintained? Can they breathe in and out? Is their anxiety being managed? If there were adverse effects, were they minor? Or if they were major, were they reported and then managed? And does the patient understand how to use the drug and when to use the drug, and et cetera, et cetera? These are all important things. So there are a couple questions at the end of this chapter. I made that short and sweet, as you should too. And I'll see you with the next video. I am going to stop my share. I will post that and see you next time. Okay.